Okay. Come on in. Okay, let's go ahead and get started. I guess we can dispense with the usual introductions, which I often do, since you all know me, and probably most of you know Karen Eden. We're both faculty here. When Lynn emailed us and said there were some openings in the schedule, I generally don't like to see that, so I thought that the department might be interested in hearing about some work that actually a number of us in the room, I see Steve back there, he was involved in this project. I don't know, Annette Totten, I don't see Annette. Anyways, and then also another reason for doing this is that we've been actually asked to participate in a webinar from our funder from this project. So I thought this would be a nice dry run for the slides that we're going to present there. Another nice thing about this project is I'm always looking for bridges across the different parts of the department, and this is a good example that the AHRQ Evidence-Based Practice Center is on the clinical epidemiology side of the department, but every now and then they get asked to do systematic reviews on informatics related topics, so it gives us an opportunity to kind of cross across the department. So basically boy, it's probably about 2 years ago now, Elaine Graham, the program manager for the Evidence-Based Practice Center, her office is upstairs on the 5th floor, came to me with this RFA and said, hey, they want to do a systematic review on health information exchange. So I jumped out of my seat. I was like, yeah, let's do that. And we applied, and we were awarded the contract, and then proceeded into this long slog, as systematic reviews often are. And anyways, and then there were a few interesting bumps along the way. But we did manage to get the program, the project done. We produced the report for AHRQ. We've actually gotten a couple of publications out of it, even a book chapter. And so this might be, thought this might be a good time to share with you all what we discovered and some of the future directions. So basically, you'll see these slides change format. I'm going to go through a few of the kind of standard basic OHSU slide I use. Then we'll switch over to AHRQ slides. And actually, we'll time ourselves because we're supposed to do that part of it in 30 minutes or less in this webinar in about 3 weeks. And so, and actually, if we'll ask if you hold any questions that you have, we should have plenty of time at the end to answer questions, and including people out in cyberspace who can tweet their questions using hashtag DMICEConf, DMICECONF, and we'll be able to answer those as well. This, as many of these sessions are, is also designated as a clinical informatics grand rounds. So physicians who want to get CME credit can do so, can get one category 1 credit, and should email Lynn Schwabe to fill out the appropriate forms. Okay, I also want to tell you about a few dates, one of which is relevant to health information exchange. I know I've mentioned this several times, and we changed the date. But on the evening of May 18th, Kevin Johnson, who's the chair of informatics at Vanderbilt, who produced a documentary on health information exchange. I've actually already seen it a couple times. It's actually a really good movie. He's going to actually be here. We're going to show the movie the evening of the 18th down at the CLSB, invite the public. There's going to be a few other people talking about HIE. Then on Thursday, he's going to do grand rounds here, do our research conference, and then also meet with various people, including at the Fellows meeting that afternoon. Also wanted to remind people everything's all set for graduation, and our usual department banquet will be after graduation, all on Sunday, June 12th. All faculty, students, and staff are invited. Just looking out into the future, September 28th, Adam Wright, who many of you know was our first PhD graduate, is winning an award. I've been sworn that I can't actually say the name of what the award is. Some people know it. But Adam is going to be visiting OHSU the first week of classes and will be given this award when he's here. And then finally, this is the 25th year of the BIC building. And on Friday, October 28th, we're going to have a big celebration. Don Lindbergh, the former director of NLM, will be here. Some of the early people who were here from the beginning, Joan Ash, myself, Paul Gorman, some of the folks from the library, and so there's going to be kind of a day of activities that probably some of you will ask to be involved with, but just to note that on your calendar. Okay, so let's move on to the talk. I'm going to give a couple slides on that won't be part of our AHRQ presentation, but just in case anyone in the audience, I know everyone should know what Health Information Exchange is, but just in case, HIE, I won't read this long definition, but basically HIE is the moving of clinical data across the traditional boundaries of healthcare organizations and businesses. So moving a patient's data from from one hospital or physician office to another, from Kaiser to OHSU, or from OHSU to Providence, et cetera. And as we'll see, HIE has been a little bit more difficult than other aspects of health information technology, in part because of this kind of business boundary side of it. So you can read this definition, which comes from the Office of the National Coordinator for Health IT website. Another succinct definition I've always liked is from Dr. Carolyn Clancy, who used to be the director of AHRQ, who describes it that basically data follows the patient where they go to get their care. Seemingly simple concept, but difficult in practice. There's three main types of HIE. There's directed HIE, so basically point-to-point direct sending of data, documents, etc. This is sometimes called push HIE because the data is pushed from one site to another. There's also query-based HIE. That's actually a little more complicated because someone does a query against typically some sort of record locator service to find out whether the patient has data from this hospital, that hospital. Some of the original HIEs, like the one in Indiana, use this sort of process, and people can query to see where patient records might exist. That is sometimes called pull HIE because you're doing a query and then you're pulling the data back to yourself. A third type of HIE we don't see much of, but could in someday become the predominant form, is consumer-mediated, where basically consumers, patients, are in control of their data, and they decide who to give access to. And things like Microsoft Health Vault and other kinds of collections where people control their own data are that. One of the this kind of got to be a famous statement in the shortly after the ONC tried to expand up HIE, that we should think of it as a verb, not a noun. HIE is the exchange of information. We shouldn't think of these organizations, even though we sometimes use this in our language. When we talk about an HIE, we're talking about a kind of organized HIE. But ultimately, health information exchange should permeate across the entire healthcare system and shouldn't necessarily need to have these HIE organizations facilitating it. But obviously, we're not there yet. So I'm looking at my watch here because I'm going to now launch into the slides that Karen and I are going to present when we do our webinar for AHRQ in a few weeks. So this is an outline of what we're going to talk about, some of the rationale for HIE, some of the past work that's been done in terms of evaluating. Our focus is on evaluating the benefits, the barriers, the limitations, et cetera, of HIE. That's what our report was about, and that's what we're going to talk about in the webinar. We're also going to comment on some future directions for research. So I don't know how well you can read this, but these are just some screenshots. This is our report. You can see all the other people that took part in this. It was a real large group effort. We did get a couple of journal publications out of it. We also have a textbook chapter in a forthcoming, it should be out any day now, book on HIE that's edited by Brian Dixon of Indiana. Some of you may know. And then this full report is at the link here. And the journal articles, the JMIR Medical Informatics one is open access. OHSU subscribes to the International Journal, so you can get that there. So many of you have seen variations on this slide of mine about how, around 2009, the HITECH Act led to substantial investment in health information technology, mainly around funding of incentives for electronic health record adoption. We've now up to something like $31 billion have been allocated to healthcare, to hospitals, to physician practices. OHSU has gotten its share of so-called meaningful use dollars. And it's really had an impact in terms of adoption. 10 years ago, we used to dream of the day that there might be more than 5 or 10% of hospitals that used electronic health records. Now, 94%, actually there's a more recent slide, it's up to like 96% of U.S. hospitals have an electronic health record system. They may not have achieved meaningful use, they may not use it all that well, but they have it. We've essentially saturated the market. For physician offices, we're up to about 78%. Emergency departments, outpatient clinics. We have achieved widespread adoption. The U.S. is no longer a laggard in electronic health record use. There's a lot of data on this slide, but the only really point that I want to make is that the rate of usage of health information exchange lags behind the adoption of EHR. So a lot of people, a lot of hospitals, physician practices, others are using electronic health records, but the use of health information exchange, whether it is hospitals, it's in the 50s to 60%. For physician practices, depending on the specific functionality, it's in the 40s to 50%. So there has been less uptake of health information exchange. So AHRQ commissioned this report because they, as they do in many topics, mostly clinical topics, but occasionally informatics topics like this, what is the value? What does the evidence show for the value of health information exchange? And so one can approach this just like any other problem in medicine. We can apply the techniques of evidence-based medicine. We'll see that there's some challenges to gathering evidence for the value of health information exchange. Usually you look at individual studies. When there's enough studies, you do a systematic review where you systematically try to capture all of the studies that have been done and then organize them. Sometimes, especially in clinical topics, when there's multiple similar studies, you can do a meta-analysis. You can't really do that with these kinds of studies. But we, as we were awarded this contract, and we kind of focused our efforts in looking at 4 areas. The effectiveness of HIE, so what kind of outcomes are seen for its benefit, how much is it used, some of the slides I showed you in the last slide, how is it implemented, and how sustainable is it. And so we were funded by this contract. If you're in DMICE, you probably should know what a systematic review is, but I will review it anyways. It's, again, basically when you look at a given area. So that medicine has always had classic, and many scientific fields have had review articles where people kind of review the literature, but a systematic review is really more focused on a specific question or series of questions. We typically involve a librarian and go through a process of screening thousands of abstracts to identify the ones that meet the criteria for inclusion. Some of you have heard of the Cochrane collaboration. It's an international collaboration that does systematic reviews, again, mostly on clinical topics. Important point to remember that a systematic review is only as good as the underlying studies. And we'll see in HIE there's a lot of mediocre studies, in part because it's a hard area to do research about. But even in clinical topics, sometimes the underlying studies are not optimal. There have been other systematic reviews. There was one that was published in 2011. And then, unfortunately, there were a couple that were done during the time that we did ours. This is always a challenge in science if someone else is doing similar kind of work. And unfortunately, these two systematic reviews didn't really need to follow the processes that AHRQ uses, such as involving key informants, putting the draft of the protocol out for public comment, putting the draft report itself out for public comment. So these folks were able, particularly these folks who were actually our competitors for the contract, turned around and somehow got some other funding source, and unfortunately published in a much more prominent journal, Annals of Internal Medicine, which publishes a lot of AHRQ systematic reviews. And so when we went to publish ours, they had already published one, and so that's why we had to choose a different journal. And then this group also had was working on a systematic review, Joshua Vest's group. Some of you may know Joshua. So this slide kind of demonstrates the literature review. So we searched multiple bibliographic databases, not only Medline through PubMed, but PsycInfo, Embase, CINAHL. Cochrane has its own database of systematic reviews. We identified several thousand abstracts and went through this review, actually so-called dual review process. We only included ones that met our criteria, and then we reviewed the full text of those, looking at things like whether they were truly HIE, whether they were the right study design, so forth, and then ultimately slotted them into our 4 categories of effectiveness, for which there were 34, use, 58, usability, facilitators and barriers, 32, and implementation and sustainability, 62. And so these were, out of the thousands that we retrieved, the ones that were included in our analysis. Okay, so then we, basically the main investigators in the project, myself and Karen, and also Annette, and the 4th main investigator was Beth Devine from the University of Washington, which is a partner in our EPC, took on different parts. So I focused on effectiveness. What do these studies of outcome actually show? So we identified 34 studies that actually investigated some form of outcome. We were hoping we would find clinical outcomes, things like patients actually developing fewer complications or achieving better health. But most of the outcome study focused on what some of you know as process measures in terms of test ordering and things like that, or on economic outcomes, how much money was spent or how much money was saved. Of the 34 studies that fit into this category, 26 of them were studies that actually measured these things. 8 of them were measured what we call perceptions, so where they asked people, do you think you ordered fewer tests, or did you think that your patients got better care, et cetera. Unfortunately, there were no studies that actually looked at clinical outcomes. And it's actually challenging to do those studies because HIE is not really like a treatment. HIE is a tool that you use to deliver care. So it's difficult to do those sorts of studies, though they could be done. And in the future research directions, we'll talk about that a little bit. So what are the areas of outcome that we found? These numbers add up to more than the 30, whatever it was, 34, because some of the studies looked at more than one of these. But these are the kinds of things that people looked at to see the impact of HIE. Laboratory testing, in particular, whether it was reduced duplicate testing, things like that, radiology testing, hospital admissions, so averting people needing to be admitted to the hospital. Certainly when I did my medical training decades ago and patients would show up in emergency departments and their records were nowhere to be found, they would sometimes get admitted to the hospital because they just didn't really know what was happening, what their previous diagnosis was. So could HIE help with that? Hospital readmissions, which continues to be a big issue. Patients get discharged from the hospital and then quickly, within like 30 days, get readmitted. Costs in emergency departments, referrals. In the outpatient setting, looking at measures of quality of care. Public health reporting is another topic, and then there's a few miscellaneous ones. So I'm going to go through these and pretty much at a high level, but just to kind of give you some of the results. So in terms of laboratory testing, so these are mostly things like blood tests and so forth that get ordered. Often, a lot of these studies are done in emergency departments, but elsewhere. So of the 6 studies we identified, 5 of them showed some benefit for HIE in reducing the overall use of tests, though some of the studies, some of the results, the impact on costs were pretty minimal because blood tests don't necessarily make up a huge part of the bill in say, an emergency department. 4 of these 5 took place in the emergency department setting. The other was in another hospital-type setting. There was also ambulatory, so outpatient setting. One of the studies actually found that there was an increase in testing when there was HIE, probably not due to the HIE itself, but in that particular study setting, there was a slight increase in the amount of testing. The radiology testing studies were kind of comparable. 7 of them showing some amount of reduced testing in the coming from emergency departments. Again, in the ambulatory setting, 1 actually showing increased use of testing and 1 decreased testing. None of these studies really looked at the appropriateness of any of the testing. It's always a challenge when you just look at, how much testing did people order. It's a lot more complicated to actually go in and try to judge whether or not that increased or decreased level of testing was appropriate. The presumption, though, is that at least for some patients, you would identify tests that they already have, so you wouldn't need to reorder those tests. A lot of tests get reordered in emergency departments unnecessarily, and that would be one of the goals for HIE. Hospital admissions, we identified 8 studies, and 2 of them found that having an HIE capability present resulted in reduced hospital admissions and lower costs. Another 3 found some benefit in reducing hospital admissions, although, again, there were 3 that found no benefit whatsoever. In terms of readmissions, the same sort of thing. 1 study showed benefit in HIE, in having HIE that would reduce readmissions to the hospital, but another study showing not. There were studies that looked at costs, particularly in emergency departments, and here you see some of the limitations of these studies. because it's challenging to measure a single patient cost. I mean, you can look at the bill for that patient, but emergency departments have overhead. Patients might get admitted to the hospital, and so then some of the costs get attributed to the hospitalization and not the emergency department. But the two studies that looked at this found that there were reduced emergency department costs when HIA was present. These were before and after kind of studies that actually came from Memphis. But, you know, one of the studies made a big deal about $1 million in savings. I know $1 million is a lot of money. But $1 million for an emergency department at a large hospital is actually not a lot of money. I don't know what the budget here for our emergency department is, but I'm sure it's on the order of many millions of dollars that, and probably dozens of millions of dollars, tens of millions, whatever. Another study looked at referrals. Obviously, HIE can potentially be of value in facilitating referrals from one physician to another or physician to a hospital, whatever. And again, there were kind of mixed results there. There were a couple studies that looked at, or 3 studies that looked at association between the use of HIE and the quality of care. Quality of care in ambulatory settings that's typically measured by process measures. So things like patients with diabetes getting the appropriate testing their hemoglobin A1C level, eye exams, foot exams, etc. There were studies that found that HIE was associated with improvement in those measures of care. There was another study that looked at medication reconciliation, which is a big issue because if you're not familiar with healthcare, you might think that patients have a single solitary list of medications that they take. But it's actually not that simple. Patients go into the hospital, their medications get changed. This patient sees a specialist who only has a partial list of their medications, et cetera. So there was actually a randomized controlled trial that looked at this HIE facilitated medication reconciliation and found that the system was good at detecting medication adherence problems, but could not actually demonstrate actually improved adherence after it was identified by providers. So you could identify that people were not adhering to their medication regimens, but it was difficult to do anything about it. There were other studies that showed that HIE does facilitate aspects of public health reporting. Some of these, I think all these studies came from Indiana, where they've been very effective at this. And you know, one of the big challenges in public health is getting the data from the healthcare system to the public health system. And these studies showed that that was beneficial. Another study actually wasn't from Indiana, I think it was Louisiana, showing that the HIE helped identify patients with HIV and encourage them to get care, to get on their medications, to improve their status. And then a few other miscellaneous studies, reduction in time. One study showed a reduction in time for processing disability claims. Another study looked at an issue that comes up in a lot of healthcare settings is people who are overly frequent users of emergency departments, and you could identify that through an HIE system. And then another study looking at finding an association, not necessarily cause and effect, but with HIE implementation and improved patient satisfaction scores, which are kind of controversial area, but it did show that. So I think at this point, well, one more slide, and then I'll turn it over to Karen. Oh, and I'm right on time. So what are some of the, what can we conclude from these studies? You know, unfortunately, I'm just kind of giving you brief overviews of 30-some-odd studies. But the big challenge with these studies is that they're retrospective. And so, as you all should know, retrospective studies always have potential confounders that may that makes it difficult to determine cause and effect. and looking at relatively limited questions. So, for example, just looking at emergency department costs without looking at the larger health system, and also focusing on absolute, on relative versus absolute costs. So you might relatively decrease the cost by 25%, but if it's a small amount of money in the larger health system, that might not be as important. There were no patient-specific clinical outcomes that were studied, and many of these places came from so-called HIE leaders. This has always been a challenge in informatics, in any area, that a lot of the research being done by people who have homegrown systems and that might not be generalizable to the rest of the world. So I'm going to turn it over to Karen's part, and then I'll come back at the end, and then we'll both take any questions.
All right, so now we're going to shift gears, and we're going to look at the evidence a different way. We're going to look at the evidence with a focus on barriers and facilitators to actual HIE. And this is opposed to planned or proposed exchange. This is actual use. So we identified 10 cross-sectional studies, 7 multiple site case studies, and 2 before-after studies that provided evidence on barriers and facilitators to health information exchange. And these data sources included surveys, interviews, focus group sessions, observations from 292 health professionals, and these were non-clinicians. They might be were affiliated with, but not a clinician, and then 402 clinicians in the U.S. We also found additional evidence from European studies, but this was dominated by one very large survey of over 9,000 providers across 31 countries. The settings were very diverse. I think Bill already mentioned that. They included exchange between emergency departments, ambulatory clinics, and hospitals, and so this made it very difficult to stratify by setting. So we took a qualitative approach. Content analysis and qualitative synthesis was performed to identify concepts for this part of the report. Concepts were sorted into groupings related to barriers and facilitators to actual HIE use. 2 investigators used an iterative open coding approach to refine the groupings and themes until consensus was achieved. And then we had a 3rd investigator who went through all of those and refined further as needed. We found 15 barriers and 20 facilitators, and they fell into 3 very broad themes: completeness of information, organization and workflow, and technology and user needs. So I'll start with completeness of information. We know that the clinicians will not continue to exchange information if they can't find the information that they need. And so we wanted to find out, well, why is it that the information isn't complete? And we found there were a variety of things that were a barrier. One is privacy and security was a concern expressed by providers as well as patients. Liability was also expressed by providers. Now, these things could be addressed with robust policy and training. So there are ways to overcome this. While some patients may be outside of the catchment area, there was also trouble identifying patients even within the exchange area. And there was some commentary in the papers about using an algorithmic matching approach as opposed to the standard approach that's taken. And finally, we found that the information about concern about sharing information with other health systems, potentially competitor systems, hospitals, was really only expressed in the U.S. studies. We did not see that as a barrier in the studies outside the U.S. So the most frequently cited barrier in the literature was the login process. If a provider had to have multiple logins, multiple passwords, this was a barrier that was hard to overcome. So the sites that had one login process seemed to have much higher use. Now, probably the most commonly cited facilitator was a workflow that included proxy users. By proxy users, I mean the admitting clerk or the registrar or the medical assistant would go in to the exchange, find out, do an inventory, what information is available, It might make a summary sheet for the provider. Then the provider could be strategic about querying for certain information. And what also came out of this literature is that there were really a couple different uses. One use was to find this inventory of information, but providers were using the exchange really for timely decision making, and were looking for certain key pieces. One group from the Mid-South eHealth Alliance reported that when a policy that allowed proxy user was eliminated, use dropped. So they saw a very clear barrier that went up as soon as the proxy users were not allowed to access the system. The sites that had the most use had a couple of strategies in place. They were getting ongoing metrics on access, seeing is it increasing, is it dropping. Also, they were collecting ongoing feedback from users to find out if the information was useful and helpful. Moving on to our third broad category, the actual technology and the user needs proved to be a barrier or could be a facilitator, depending on how you approached it. Sites with more complete integration, meaning information was pushed to the provider systems, naturally were used more, as opposed to requiring providers to have to go in and do an extensive amount of querying. Sites that had a very complete hospital portal, meaning the information was very thorough in the hospital portal, that meant the provider could go to that portal and might not also then seek out information in the exchange. The other thing that was in the literature quite a bit was the actual HIE reports. The reports that lacked context related to the patient, was missing information proved a barrier, and also reports that had way too much information proved to be a barrier as well, because the providers wanted more of a filtered, a streamlined bit of information, and not just to be overwhelmed with information. And finally, there was concern in some of the studies about the lack of data standards in HIE, and more work is needed to understand that better. Now, this work was actually kind of hard. There were some challenges that we had to overcome, and one of them was the changing nature of HIE and workflow locally. So as an HIE, as exchanging began to go forward, there might be some inefficiencies in workflows that would be identified, and then the sites would work to refine that workflow so that it was efficient to do the health information exchange. However, the same thing can happen on the other end, in that as more and more information was flowing, then the providers were getting way too much information, and they wanted some kind of a streamlined effect to be able to get more specific and filtered information. So there would need to be some ongoing effort to see if workflow needs to be adjusted. I think Bill mentioned there was a lack of standard HIE classification and terminology. You know, things like the architecture weren't described the same way. Function was not described the same way. So it was really hard to make summary conclusions about a particular type of system. And finally, we saw that there was a lack of consistent or coherent theoretical framework underlying the implementation and also the evaluation. In fact, only one study was really transparent about the theoretical framework that they used to evaluate the system. So there's a fair amount of future work that we need to move forward with. The evidence is really inadequate to compare barriers to use by type of function, as I mentioned, whether it's query-based or pull or directed or pushed, and also by architecture, whether the information is centralized or federated. Understanding the optimal functionality of HIE is challenged by lack of consistent classification and terminology, and the changing nature of these systems. So these are some of the things that I think could be addressed in the future.
Then just kind of, oh, actually, this one was yours, wasn't it?
Oh, yes, that one was mine. So while the evidence is currently incomplete, there were several facilitators. They really centered around those main themes I talked about: obtaining more complete information, thoughtful implementation and workflow, and including users and identifying key functions in use.
Okay, and then so we, in the end, you can't just sort of talk about all these results and be somewhat critical of them without having some idea for future research needs. Clearly, doing research about HIE is challenging. You know, like I said before, you know, it's not a treatment. You know, it's not a drug that you can just, you know, randomize people and blind people and so forth. So you can't. You can probably do classic randomized controlled trials on certain aspects of it, but you need to think about other methods. And then, because it's difficult to do things like randomized controlled trials, people do these retrospective studies, which can be useful, or sometimes retrospective or before and after. But again, as is true in any type of research, when you anytime you look back retrospectively, you have no ability to control for confounders. And there's many famous studies in informatics. Some of you may remember the Hahn study of CPOE it's about a decade ago now, that they made all kinds of changes, one of which happened to be CPOE, and there was actually a higher mortality rate, but you couldn't really tell whether the mortality rate was connected to the CPOE because they made so many other changes in the process. So clearly, prospective evaluation is the best approach. One of the possibilities is to, even if you can't do controlled studies, you can still do prospective observational studies where you can look at things going forward. And now that we have these EHR systems that are collecting data, we have these HIE implementations and so forth, that might be a possibility. Plus, we have these ever-growing secondary collections of data. I call out PCORNet here, the PCORI Clinical Data Research Network, some of you may have heard of, that are just accumulating large amounts of data of patients across different health systems and so forth. And of course, as Karen stated, the technology's changing, and there's a lot of advocacy for, even though in some places we have pretty good HIE, and other places there's no HIE. Actually, if you do go to Kevin Johnson's movie in May, you'll see some interesting stories. The movie is a documentary, but there's some very moving stories about both the benefits and also HIE implementations that were not sustainable, because part of the challenge is how do you pay for this sort of thing when you're basically sending your data to your competitors in the healthcare marketplace. Of course, if you believe conceptually that patients own their data and that a responsibility of a healthcare organization is to move the patient's data when the patient moves, then you could argue that HIE is the cost of doing business. But Karen also talked about standards. I got all excited yesterday that there's an article published on the preprint on the JAMIA site about the Smart on Fire, which is the big new emerging interoperability standard that will hopefully facilitate more HIE. So that's all we're going to say. Most of us were funded by AHRQ because Steve was an NLM fellow. We can actually claim that this work was supported by the NLM training grant. So we have finished about time, and we have some time for questions. So if anyone has any questions, let us know. Please make sure you push the button so people listening in cyberspace can hear it. Questions, comments? Oh, yeah, sure. Can you push the button? Thanks.
So my question is actually like for your earlier slides, and not the latter slides. But you showed a graph, the growth of use of EHRs, and there was two. There was a blue one and a green one, and I think the green one was non-approved or something?
No,
certified versus basic.
Well, yeah. Not. I didn't really go into the details on this, but these are like when they say any EHR, these are people that basically just have an EHR system. Their basic system means that they actually use it for some relatively basic functionality. So this just kind of gets to the point that we do have a lot of adoption. People aren't, using it for all the functionality that they could. Yeah, push it.
Sorry, my question would be also, is there any data on if there's a adoption of the more certified from the basic?
I don't think there is. Most of these kind of basic functions include, pretty simple things like the clinicians entering orders. The ability to do health information exchange is among the meaningful use criteria, although these graphs don't get at people who have achieved meaningful use. But there is that, the ability to do that. And one of the many criticisms of the meaningful use program is that there wasn't enough emphasis in the meaningful use criteria put on health information exchange. Some people argue that that should have been the focus rather than what proportion of people use problem lists and computerized order entry and things like that. Yeah, Steve.
I'll just add, so Issa, this is actually the NAMSIS survey, so it's a CDC survey sent out to ambulatory care providers. And since 2014, there's a supplement to it that some subset of those providers get, and actually asks them about further questions, including, do you participate in health information exchange? So there hasn't been a lot published on it, but there's been a few charts and tables from the CDC about it.
Great, thanks. Yeah. Catherine, maybe can you push the button? Yeah. Okay.
How do you think we can move towards standardization of the terminology and classification?
Yeah, great question. How can we move towards standardization of terminology? Well, one is that we start, mandating its use, like the meaningful use criteria do. Problem lists have to be in, I think it's either ICD or SNOMED. That needs to be part of the, the regulatory framework. But we also need to make it easy to do, which we haven't always done. So it's not just we need to start telling people, you need to use LOINC for lab tests and this and that, but to actually make it relatively easy to do that. Some of that might be putting some of the onus on vendors so that in order to get their systems certified, that they are, required to use those those terminology systems. I think I saw another. Yeah, Nathan.
I was just wondering if the other systematic reviews looked at the same papers or what the kind of overlap there was.
Yeah, great question. Somewhat. They were less focused. The one by Rudin and colleagues that was our competitors for the contract, they really narrowed their scope. I mean, they pretty much came to the same conclusions that the literature is challenging, but they limited their focus to the U.S. They limited their focus to healthcare and not public health. But their conclusions. So they kind of looked at a subset of the literature that we looked at and pretty much came to the same conclusion. The Rahurkar, I think that's how you pronounce that person's name, but that works with Joshua Vest, they looked at some different questions. They tried to look at the quality of studies and how that impacted the outcomes, but pretty much came to the same conclusions. It's in all honesty, it's a kind of unsatisfying conclusion that the quality of the studies really, don't give you the ability to really develop a lot of detailed conclusions. But that's basically what we found.
I wondered if you looked at how the studies were funded for each of the papers.
No, we didn't look at that. I imagine that most of the studies were funded, were government funded. A lot of the, some of the, there was a fair amount, some of the high tech, about $500 million out of the $30 billion of high tech went to state-based health information exchanges. So states got money and there were requirements for evaluation. And so some of those studies came out of that. I suspect that probably government funding, maybe some foundation funding too, was the source, but we didn't look at that question explicitly. Yeah, Michelle?
This question is for something that Karen was talking about. You had mentioned that one of the confounders was that there were some providers using a hospital portal instead of HIE. I was just wondering what that meant. Like, what is a hospital portal, and how is that not HIE, or is HIE, or?
Unfortunately, they didn't really give a whole lot of detail other than because the information was fairly complete in the hospital system, the providers were less likely to seek it out.
So one sec, we have a question that came in on the Twitter feed from Emily Dragowski. Interesting talk. Can HIE work if institution internal clinical information remains fragmented and siloed? And the answer is that it makes it a lot more difficult. Any kind of siloing of information, it really kind of gets back to the standards. If even we tend to talk about healthcare data being fragmented across institutions, but as probably many of you who work in institutions know, you can have fragmented data systems within an institution. Your lab system doesn't talk well to your patient repository, to your EHR, and so forth. So, I think that most of us would agree that the more standardization we can achieve of data across different information systems, the easier many things will be in healthcare, including HIE. So, Dion, you were going to?
I was just going to reply to Michelle's question.
Sure.
In Portland, we don't really have a good HIE, but we do have portal access. So like where I work, I typically will get a patient in, and I'll actually query 3 of the 4 hospital systems in Portland to try and find out what's going on with my patient, which is a pain, but it also reduces some of the demand and usefulness of an HIE.
Actually, the de facto HIE in Portland, like in many cities, is the Epic Care Everywhere, where you basically Epic allows you, and I guess they do this beyond just Epic records, but you can basically bundle up data from one Epic system and move it into another. Now, because it's not standardized, it doesn't populate within the database. You get a separate tab that has all the external data. But I know that at least here, they get data from a lot of patients, though they don't get everything, and sometimes there's still pieces of data missing and so forth. So, yeah, Aaron.
Yeah, I was just wondering, it's sort of related to this question with the condensing of the health systems and the condensing of the EHRs, I guess. Was there any discussion in the literature you looked at how that angle impacts the ability to access information or HIE? If everybody in a region, for example, is on Epic, is Epic, is that really HIE, even though we don't designate it at it? And similarly, as the health systems are condensing here, it seems like it's going to be harder to get any care outside the health system. And so if the HIE or at least the access to information is all within a certain health system, because that's all your insurance will let you go to, is that HIE, and is that going to be adequate? So I just wonder if any of the literature talked about any of these, the theory of HIE versus where the practical needs are and how the changing health system is impacting where the need boundaries really are.
Yeah, so I don't, a lot of these studies were sort of, this is the HIE environment that we have, and, so this is how we studied it. But we know with all the consolidation of health systems, so actually there's another kind of terminology that we didn't really get into, but people talk about public versus private HIEs, and whereas, private HIEs are HIEs for like a health system across a region and things like that. And those are the more growing kinds of HIE. These public ones across entire states, they've succeeded well in some states, like Indiana, New York, and others. They tried to do it in Oregon, really while there actually is one HIE in Southern Oregon, the Jefferson HIE, that actually facilitates a lot of HIE across all the hospitals and physician offices, mostly in southwest Oregon, although they're kind of percolating up to Bend and things like that. And also, the state facilitates the use of the directed exchange. But yeah, as no one's really, so there really isn't an answer to your question, but with the consolidation of healthcare systems, in some ways it might make HIE easier because, yeah.
Well, I was going to say, the traditional HIE has this upside-down economic incentive of, putting money into helping your competitors do a better job. But if it's focused on these expanding and number decreasing health systems, the economic incentive is to do HIE within the health system so you can, reduce cost and provide better care, potentially a competitive advantage. So I wonder what those, if the economic incentive flip will at least make some AHIE more successal.
Sure. As we move to more coordinated models of care, where it's actually of value to an organization in the traditional fee-for-service system, there's actually incentive to just repeat a test, because you repeat a test, you get paid for it again. But in a more of a value-based environment like the coordinated care organizations, where you're sort of getting a bundle of money to take care of a patient with a specific condition, there's actually value in saving money and patient not getting readmitted to the hospital and things like that. I did see one other question from Ilya, one of our fellows. Do you plan to research on how HIE implementation can affect clinical outcomes? That would be a very interesting question to research, and that would involve, of course, writing grants and finding funders and things like that. But I think it would be good, although, again, there's a number of challenges, not the least of which is the constant state of flux of HIE, of EHR technology, of changing healthcare organizations, but that would be a good question to study. Yeah, Dana.
Some of the HIEs are exploring value-added services like offloading reporting responsibilities. Is that working? What did you learn about financial sustainability of HIEs as entities?
Yeah, actually, I think Annette just left. She actually did that part of the report. From what I know about this area, like Indiana, the Indiana HIE, they sustain themselves with a number of, kind of services that they provide. Like, for example, the freestanding labs that, they actually found it was actually cheaper for them to deliver the results electronically than to print it out on a piece of paper, stick it in an envelope, put on a stamp, and mail it. So early on, that actually funded a fair amount. But a big issue still remains with the financial sustainability. Some of you who were around Portland maybe 10 years ago, in the pre-high-tech era, there was this effort to try to create a metropolitan Portland HIE, kind of modeled on places like Indiana and New York. And the whole thing, there was a great plan.